Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we're going to be talking about hemorrhoids, old and bothersome. I have Dr. Peter Lee here with me. He is with Arizona Oncology. He is part of the he's a colorectal surgical specialist over at Arizona Oncology. How are you, Dr. Lee?
I'm good. Thank you, Maya.
Yeah, so Dr. Lee, you were here. A couple months ago, sharing with us, and today we were talking. I think back when you first presented, and you said, you know what, I actually do a lot about hemorrhoids. So we thought that's not a topic that we have ever covered before. So we're gonna give this a shot today. I've gone ahead and put your PowerPoint up. You do have an online audience that is watching. So if you are watching from home, please feel free to leave any questions for Dr. Lee in the chat, and I will get those addressed afterwards. So I'll turn it over to you.
Well, thank you for having me today, Maya. My name is Peter Lee. I'm a colorectal surgeon here with Arizona Oncology. Even though it's an oncology office, we actually deal with a lot of non-cancer stuff, such as hemorrhoids. So this is the other side of things that we do see. It's a very big part of our practice, in fact, because unfortunately, I want to say even doctors don't really know what to do with it. You go to your family doctor and they're like, okay, I don't know, or go see Dr. Lee, or something like that. That's usually what happens. The presentation is not that long. It's mainly, I wanted to use most of the time for you guys is to answer questions you may have that may come along here, okay? And also with any other colorectal issue you may have, all right? So what do you think of when I mention the word hemorrhoids? The first thing is the itchy butt. People think of the monkey red butt. This is a mandrill, and although their butts are not red, they're actually pretty with multiple different other colors. That's what they think of. It's itching. You're scratching it, and you can't really get rid of the itch, and sometimes it bleeds, and then sometimes you get stinging pain. This was a meme I found. You get actually a bumper sticker for your car for that. That's actually a really good one. I might need to get that for my car. And then symptoms. Some people talk about hemorrhoids. They're talking about pain, and it feels like razor blades. And other people are talking about bleeding. So hemorrhoids, unfortunately, is one of those trash bin diagnosis where everything that's wrong with your anus or your rectum becomes automatically, it's a hemorrhoid problem, okay? But it could span a whole sort of, from anything with just itching, could be irritation, it could be bleeding, it could be pain, it could be cancer, it could be many different things that when you ask somebody on the street, hey, or somebody has a problem with hemorrhoids, it could refer to any of these conditions. I'm going to first start off with the basics. So what does it mean to me as a colorectal surgeon to have, to be presented with somebody with hemorrhoids? Well, hemorrhoids by definition in the strictest sense, are the cushions of veins at the anal verge, okay? So there's two areas. There's the external set and the internal set. And this is a cross-section of your anus. When a doctor does a rectal exam, the finger comes from outside, inside, and he's feeling for masses, bleeding, sinuses, things like that, okay? So everybody has two sets of hemorrhoids, internal and external. The interesting thing about this is the internal hemorrhoids actually behave differently than the external hemorrhoids. So there is this scalloped edge here. This is called the dentate line. This is the separation between the anal canal and your rectum, which is up here. So the thing is, any tissue or lining of the skin up here above this dentate line does not possess pain fibers, okay? On the other hand, everything below does have pain fibers. So if you have an external hemorrhoid that's inflamed, it will feel itchy, scratchy. You could have pain, the razor blade stuff, that you can feel. However, a frequent presentation of the internal hemorrhoid is painless bleeding. So most people who complain of rectal bleeding, it's usually from internal hemorrhoids, okay? Now, everybody has been born with hemorrhoids. Okay, if you say, "Oh, I have hemorrhoids because I was pregnant and I had like this really hard birth and I got hemorrhoids from my first pregnancy," well, everybody else has hemorrhoids too. The question is whether they become problematic, and usually problematic is because they're enlarged. They can either thrombose, which is clot off, they can bleed, or they can present with pain and irritation. Like I said, there was 2 sets. They sometimes frequently present in different ways. And depending on what your symptoms are can help us differentiate between the 2. Usually internal hemorrhoids, sometimes, well, not usually, a lot of times you can actually treat internal hemorrhoids without surgery, as what we call hemorrhoidectomy, going to the operating room, adrenal anesthesia, the thing that people complain about hurting so much, okay? We can do office procedures, and they're fairly well tolerated because there's no pain fibers there. On the other hand, external hemorrhoids usually will require at least local anesthetic, if not even general anesthetic, for us to fully remove these, okay? So, I want to say when somebody 50% of the patients who come to our office with the diagnosis of hemorrhoids as the reason for visiting me actually have something else, okay? They can include inflamed skin tag on the outside, and those are frequently the ones that you feel when you're wiping your butt. You feel like, hey, there's this extra piece of skin or something, and it could be a skin tag. More seriously, you can have an infection or an abscess. Typically, you'll feel some swelling on the outside, and it feels like a swollen golf ball. You're like sitting on an egg, and it's really painful. And you can have fevers, you can have, because it's an infection. And so long as it doesn't get treated, the pain gets worse, the abscess gets bigger, and until one day, it might just rupture by itself, and then you'll feel better, but you still have the infection that's in there, okay? Sometimes abscesses after drainage or, actually most of the time abscesses and infections will heal on their own, okay? After drainage procedure, they might pack it for a day or 2, and then, or if it just drains by itself, it may go away. Most abscesses, that's what happens. It starts with a little anal gland that actually lives right here at this scalloped edge, and they get plugged up with poop or bacteria, and it develops into an infection. And then most of the time, if the pus is able to get out, and then basically the body goes into repair mode, and then the whole thing just scars up and then goes away. You'll never deal with it again. About 20 to 30% of the time, the abscess does not fully go away and ends up being a fistula. So a fistula is basically the tunnel, and you see a picture here of an anal gland here. When this turns into an infection, develops here, and it drains outside, now you have a hole going from the inside all the way to the outside. And that can become the source of future infections because it didn't fully heal and sclerose and scar down to just nothing, okay? So there's still a pathway for stool and bacteria to travel in here to give you problems. Another thing that can happen is called a fissure. Fissure is basically a superficial skin tear here in the anus, okay? And it's superficial, and I usually use the analogy of a paper cut. Paper cut doesn't look that bad when you look at it, but it might bleed a little, but it hurts really, really a lot, okay? And the reason for that is, A, you're in this area which has pain fibers below the scalloped edge, and most fissures will heal on their own after a couple of days, maybe a week or 2. But sometimes either the cut is too deep and it involves the muscles a little bit. There's granulation tissue. The anus is also a very dirty area. The stool that sort of gets on the surface, and you probably won't be able to clean it that well because it's hurting. So you don't want to wipe harder. It just gets you into this vicious cycle of the thing not healing. And then, in which case, then you need other treatments to help that heal. We have certain creams and ointments and things like that that can help relax the muscle, cut down on the infection. And some people may even need surgery to cut the muscle because it's cramping down and spasming too much to allow that to heal properly. Another common thing that we would see is something called pruritus. Pruritus is just a Latin word for itching, okay? Those are basically when you've looked at everything else and ruled everything else out, and we don't really have a real good reason for the itching. By the way, itching, abscess, or a fistula can give you itching. Sometimes fissure can give you itching, and definitely an inflamed skin tag can give you itching. But this is if we don't find, in the absence of all these other things, and we have no idea how to call it, then pruritus could be what you have. Very rarely would it be a cancer. So this is the problem with anal rectal issues. One, how are you going to look at it? You can't see what's going on down there. You can't see, and then for us, we actually have to spread the butt cheeks apart and do all these things and wear a headlight. It's going to be hard for you to, first of all, to look and see what's really wrong there, unless you feel a lump or a skin tag or see blood on your toilet paper. Some of us are lucky enough to have a spouse that's willing to look at your butt, all right, or take a picture of it with your cell phone so that, and then sometimes that can give you information, but frequently that does not, because they don't, for us, we essentially do a rectal exam to put the scope in there to look internally, okay? So a lot of times, and when you go to the family doctor and say, I have hemorrhoid problems, the only thing they can really do is a rectal exam to look for a mass, look for blood, or what was the other thing? Or they see a thrombosed hemorrhoid or something like that on the outside. They don't have the scopes that we have in the office. So a lot of times, go see the proctologist or the colorectal surgeon, and they might just give you some hemorrhoid cream like anal pram or anti-inflammatory to see if that makes it go away. And actually, remarkably, a lot of times it does. Unless you have one of these things sometimes. Obviously, if there was a cancer, it won't go away with just putting the anal cream or something like that. So, that's the reason why it's really important afterwards to come see one of a doctor like me or a proctologist so they can get a better look at this, okay, to make sure it's not something more serious here. So, how do you prevent from getting hemorrhoid problems? The majority of hemorrhoid problems is because people are constipated, they're straining, they don't drink enough fluid, they're not enough fiber. So, I would dare say most people in the Western diet do not eat enough fiber. Fiber comes in all forms. It could be from your diet, so like vegetables, what your mom used to tell you need to eat roughage, that kind of stuff. Surprisingly, there's also a lot of fiber in beans and what else? Nuts. There's fiber in nuts. So in the Western diet, it's hard, and I think that most people, even vegetarians, don't appear to get enough fiber in their diet sometimes. So we recommend doing some sort of a fiber supplement. But when the first thing patient comes to me, when I ask them, so how much fiber do you eat? Well, I don't know. I usually say at least 5 servings of fruits and vegetables, which is what the USDA, whoever does all those nutritional recommendations are. 5 to 7 servings of, and whole grain, and whole grain is also another good source of fiber. So like, what is it? Brown rice, whole grain wheat bread. Those type of things can also be a good source of fiber. The vast majority will require some sort of fiber supplementation. So it's going to be Metamucil. And here's the thing. Metamucil is not the same thing as Miralax. I frequently find that patients are confused between the two because they both start with the letter M. Okay? Miralax is actually a laxative. Yes?
Could you repeat that?
Metamucil versus Miralax.
Okay.
Okay? So they both start with M, and I feel like a lot of people get confused that they're the same thing. Miralax is not a fiber supplement. It's a laxative, okay? And it basically is a really powerful stool softener and keeps water in your stool so that it'll be easier to pass. Fiber, on the other hand, acts more like a conveyor belt in your digestive system. It keeps that conveyor belt moving, so that you don't have slow down or anything like that to cause constipation. Because what happens when you're constipated is you need to strain sometimes to get the stool out because it's harder. And sometimes the stools are bigger than your anus. And so then you have to put a lot of pressure to push it down. All that pressure, when you sit on a toilet and strain, what are you doing? You're holding your breath, you're contracting your abdominal core muscles, and you're like taking a deep breath almost, okay? And what that does is, so your belly muscles, your six-pack muscles are tight, strong. Your diaphragm's very strong. And then your sides and back are also very strong muscles. And what's left? Your pelvis. Well, actually, the pelvic muscles are pretty small and thin. And especially if you're a woman who has had multiple children, like even 2 kids might be enough to make people's pelvic muscles weak. That's why they recommend, as you get older, you do those Kegel exercises to strengthen those muscles. So all that pressure that you're exerting will be transmitted down into your perineum. And what you're doing is essentially trying to push all your guts and everything, not just the stool, and you're just trying to like squeeze everything out through your pelvis or your anus or that area down there. So especially if it's tough and you're like, you're closing your eyes and, putting a lot of pressure, that repeated, when you do this over and over again, eventually your rectum will want to come out. Your muscles get even weaker because it can't overpower a lot of the other internal pressure that's causing you to allow you to have that bowel movement. So that is one thing. So the fibers sort of keep some water in the stool so it's easier to pass and to not let it build up. And the next question would be, well, how often do you need to have a bowel movement to be considered not constipated? Well, it varies from people to people. Some people go every day. Some people go twice a day. Some people go, every other day. For most people, I feel that as long as you're going twice a week, it's okay. And you're not straining, that is, and you're not having the really hard stools. Ideally, once a day is most people are going to say once a day, but I don't think that that's necessarily true for everyone. So an apple a day keeps the doctor away. So that saying is very true because an apple contains about 4 grams of soluble fiber, okay? That translates to 9 apples a day, and I don't expect everybody here to eat 9 apples a day, but here's the thing. It's the 25 to 30 grams, 25 to 40 grams a day, is all your diet. So that's why, again, I would tell you to take Metamucil, Citracel, or FiberCon. Some sort of, and they also have fiber gummies now, and they have also the fiber crackers or wafers or whatever. These are all sold in the same area. I think Metamucil sells it. Other things of high fiber source would be like Fiber One cereal. They sell the granola bars that have the Fiber One. Fiber is actually something that's listed on the nutritional label these days, and you can keep track of it on a phone app or whatever. You can keep track of fibers. You can keep track of other things. Interestingly, we also give fiber for people with diarrhea because it helps bulk up your stool. And the analogy I give is like kitty litter, okay? It clumps it up to make it easier to come out. And so to me, fiber is one of those things that keeps stool in the happy medium. Not too constipated, not too loose. And so therefore, I think that fiber is one important component to be pay attention to so that you don't have a problem with hemorrhoids. Not just hemorrhoids. Some of those other symptoms I talked about, an anal fissure, can be caused by one particularly large bowel movement, and then you pass it, and unfortunately you cause a tear or the skin tear down there. And so that can keep that from happening too. We talked about the avoidance of straining and avoiding constipation. So what that means is don't strain regularly. If you find that you're straining regularly, then A, I would say check your fiber. B, are you drinking enough fluids? C, are you, despite all, and if those all check off that you've been doing it. And fluids for me, actually, I've been telling people you need to drink about half a gallon a day of some sort of fluid, okay? And ever since I moved to Tucson, I've been finding that you actually need to drink closer to 1 gallon a day because of the hot weather and the arid climate that we're in, because we're all losing it through our nasal passages and your skin and sweating and all that. So, you could take all the fiber you want, but you don't chase it with water, it just becomes this dry mess. And the thing is, fiber also hangs onto water to help soften the stool as well. So we talked about how often to have no straining. So you should limit your time on the toilet to less than 5 minutes. 10 minutes if you have to, occasionally. Why is that? So, and that goes to don't dwell on the toilet. Don't sit on the toilet for more than 5 minutes. If there's nothing there, get up, go do something else. Don't sit there and read. Don't check your phone. I now find that you can install a TV in your bathroom, and unfortunately, that's not a good thing. Why am I saying that? So on a toilet, you're sitting on a hole, essentially. So the sides of your butt is supported, but the middle is not. And it's, A, you have gravity fighting, or not gravity trying to, let stuff come through. B, you're straining to get that poop out. And C, that pressure cannot be relieved because it's all downward pressure. With time, that can lead to prolapse. And first, some females here may have some gynecologic prolapse where they're like their uterus is turning, not your uterus, your vagina is turning inside out. This would be a similar sort of situation, except that we're dealing with your rectum, with your anus, okay? And that again comes back to your pelvic floor needing to be strong enough to support stool. It could also be related to the angle where your anus and your rectum are. So normally, when you poop, your muscles relax or contract in a way that it straightens out your rectum and your anus so that it's a straighter shot for the poop to come out. So sometimes if you're always holding it, or that may not happen, and that's why you have constipation, okay? But that's why relaxation is also important, to make sure that you're not just, having too much stress and having difficulty with constipation. Last thing for prevention is pregnancy. Well, pregnancy is definitely associated with hemorrhoids, okay? Because carrying the baby increases the abdominal and the pelvic pressure, and then the blood flow can't come back, and then sometimes they're straining because they're constipated from being pregnant. And so, usually in those situations, it's self-limited after the baby is born and they deal with the hemorrhoids at one time. It doesn't really come back, other than if they have the thrombus hemorrhoids with the tags on the outside. Okay. Oh, yeah, I forgot. They also need to be on iron supplements, and that causes constipation because of, So we often see a lot of them with thrombus hemorrhoids. And again, even if you get thrombus hemorrhoids, a lot of the treatment is conservative. Just take some time and it'll go away. Lifestyle issues. So if you do a lot of heavy lifting, if you bench 350 pounds and you're training to be an Olympic weightlifter, well, what are you doing? You're basically straining all the time, every time you lift up those weights. That can cause it. People who have very heavy lifting at work, like letter carriers and things like that, they are at risk. Sedentary lifestyle. So what does that mean? Why would that cause hemorrhoids? Well, people who have sedentary lifestyles, they're not moving around. I like to use the analogy that when you walk around, you're jiggling your guts back and forth, and that helps promote, motility of your gut. And you don't, if you sit around and the gut just sort of sits there, well, then it sometimes may not want to move. I give the example of my daughter. When she was 3 or 4, I had a horrible time trying to get her to go to the bathroom to poop. We took her to, I forget, it was the state fair or whatever, and we did a walking all day. That evening or the next day, poop right there. So I think that activity is important because it promotes gut motility, and that you can have bowel again, and so you don't have constipation. It goes back to that original tenet. However, a lot of patients will come to me and I can't find a darn thing. All right, they're doing their fiber, they're not constipated, they have bowel movement every day, they're not straining. And so in those situations, then treatment might be necessary. And again, this is because we've done all the other things. So actually, for the patients who come to see me for hemorrhoids, I would dare say only about 30%, 20% end up needing surgery. There has to be a really good reason for surgery because surgery hurts. And also, recovery from the surgery it's not the surgery itself, it's the recovery period. It's very painful. Usually, I would say you need to take 2 or 3 weeks off because 2 or 3 weeks off, okay? Because they're in so much pain, and it's just, if you can avoid it, don't have surgery. And this is coming from a surgeon. So the initial treatment is, the majority of problems that we see is thrombosed hemorrhoids. Usually it's keep it simple. Warm baths. The ointments typically don't work unless they have a numbing agent, because what you're hurting from is the inflammation from the thrombose or the blood clot that's sitting in that hemorrhoid cushion. And if you do an ointment, it may help in the way that you're preventing trauma to it. If the pain is so bad that you can't sit at all, well then, at that point, then you need to have that blood clot evacuated, either with an incision or with a drainage, like stick a needle and suck it out. Usually I do the drainage, or sometimes we just cut it off. Typically, your time frame is about 3 to 4 days. Because if we do cut it off or open it up, what happens is now you have this open sore. Hemorrhoids, usually you don't want to close them because it's not a very sterile environment. There's a lot of stool there. And if you close it, sometimes you can trap the bacteria or whatever that's normally there underneath the skin, and that can lead to an abscess or an infection, which means you're coming back, and then we got to deal with that. So, most studies have shown that if it's beyond 4 days, usually the pain and stuff like that are going away. And so doing additional cutting out doesn't really make any sense, okay? We have a problem in the office that when it gets really busy, like now, the wait to come in and see us could be 3 or 4 weeks. And by the time that the patient comes in and sees us, it's already either ruptured and gotten better, and they're not sure why they're here. And so we try to get thrombosed hemorrhoids in sooner than later so that they can be addressed, because then during that 3 or 4 week time, they were miserable for at least the first 1 or 2 weeks. So that's why we usually use the cutoff of 4 days to see, whether cutting it out would be beneficial to you. Like I said, like wiping or blotting. The warm baths also help because that cuts down on some of the muscle spasms that occur down there after inflammation of the area. And pads. You may have some drainage. It might be harder to wipe after bowel movement because you've got this lump there that's painful and irritated. So, and the other thing that I've found that we don't utilize a lot of in our culture is that the use of bidets, okay? It's more popular in Europe and Asia. They don't wipe. Toilet paper is something of North Americans, okay? They don't do that often over there. And so by just irrigating it, or doing a sitz bath, it may be not, it won't be traumatic to cause, to make the inflammation and the irritation persist. Concerning symptoms to me usually are, if somebody says they have hemorrhoids, like I said, it's a trash bin of diagnosis. My concerns would be for bleeding, pain, burning, itching, constipation, things that basically are not going away or progressing. So, because you can't look at it, and whoever else is looking at it may not know what they're looking at. And so that's why I think that it's worth a visit to us, just so that we can say, oh yeah, a professional looked at it and oh, you got nothing to worry about. This will go away. Just do some sitz baths. I would say the vast majority of our patients end up needing that sort of reassurance. The other person would be, even if they're minor, they are affecting your life. You cannot go out because you worry about having to scratch in public, or, and then it's very uncomfortable to sit. All these other things where it could mean that there's something else that's going on that needs to be warranted. The one more comment I have to make is that people say, oh, well, I'm having my colonoscopy next week, so they'll see what's wrong with there. The problem with colonoscopy is it doesn't look at the anal canal that well. Colonoscopy works because when you're going in the rectum, they're putting air in there. It's filling up like a balloon. And so everything's sort of going away and then flattening out so you can look at any abnormalities here. You cannot do that with a muscle sphincter of the anus. That requires a different kind of scope, which is what we do here in the office. Okay, so a colonoscopy doesn't, and they will always say, oh, I see internal hemorrhoids in there. And like I said, remember, everybody's born with them. So don't be freaked out when you get that on your report. So why is it for the appointment as important as basically we're looking for the cause? Thrombus hemorrhoids, which we can do something about. Prolapsing hemorrhoids, which we can ban. There's some procedure you can do in the office. A fissure is something that we usually just give you a cream, which is a muscle relaxer to help relax that muscle. It's actually a heart medicine, like nifedipine or diltiazem or nitroglycerin. The problem is that that type of medicine isn't sold at a pharmacy. You usually have to get it at a compounding pharmacy to get those. Other things we see are pruritus ani, and like I said, the more serious ones will be the infections that we have to drain. And frequently we can drain those in the office. If your family doctor calls us and say, hey, yeah, I think my patient has an infection, we can usually get you in that day or the next day. It's actually easier for us when we get the consults to do them in the office rather than the emergency room. Because in our office, we have these special tables where you're basically prostrate on a chair, and we can drain it. We have much better visualization than you lying on your side in the bed in the emergency room. Other things we look for are obviously the fistulas and the cancers. When you come in, you have the consultation, we'll examine you. We can possibly do an office-based procedure. Maybe it's that tag, maybe it's the thrombus hemorrhoid. We can do the band ligation. IRC is a laser type surgery where we do, but I haven't done it here. I don't think it works well under my hands, but there are some providers that will, use laser treatment in the office for some of these hemorrhoids. And then we talk about surgery if you need to have surgery. Sometimes the surgery isn't necessarily a surgery. We frequently do something called an exam under anesthesia. Obviously, if somebody's in a lot of pain, I have to make sure there's no very serious, abscess or something like that going on. And if I cannot do the exam in the office because it's too painful, I may say, well, then I need to do the exam when you're asleep. And then we might need a biopsy, all these other things that we need to do to rule out some of these more serious diagnoses. And so that is not surgery per se, but it is part of the diagnostic process for us to lead to a treatment for that problem. Hemorrhoid surgeries. So there are two kinds of hemorrhoid surgeries. There's the ones that you do in the office and the other ones that you have to do in the in the operating room under anesthesia. So it's traditional hemorrhoidectomy is the one that you hear about. Oh, I'm in so much pain for 3 weeks. That's the one. Usually I do it for patients who have very large hemorrhoids that cannot be banded, or some of these lesser treatments. It hurts a lot, but there's a reason why we have to go to those lengths. For example, if you have atrial fibrillation and you are on a blood thinner, you cannot be banded, because when you band, you wait for the hemorrhoid to fall off, and you have this ulcer which can start bleeding. And you can bleed to death from that because you're on a blood thinner. So then in which case then we need to do it in surgery, so then we can close the incision and reduce the chances that there are going to be these type of bleeding complications. So, the choice may also be very patient specific. I have patients who have very large hemorrhoids that I said, hey, you know what? I think you need surgery. I'm sorry. These are too big. I can't take care of them here.
How big is that?
About the size of my thumb. They're pretty big. The other thing is, it feels like hemorrhoids are sort of like prolapse. It's as if I turn my lips inside out, and this is hemorrhoid tissue, and when this is rubbed on toilet paper or your underwear and stuff, that bleeds. It gets inflamed and it bleeds. But I may get the response, oh, I'm a retail sales worker, and right now it's Black Friday, and I can't take any time off because it's the busiest time of the season. I was like, okay, that's fine. Why don't we just keep banding until, a time where you're not getting these serious bleeding episodes, and it's January, and then you got time again, and then have the surgery then. So it may be different for everyone depending on their life circumstances. Hemorrhoids are not cancer. It's basically, I usually say, schedule it around your life, unless your life is so wrecked from having your hemorrhoid symptoms, in which case then it takes priority. So, if I don't get through to you, is basically maintain an active lifestyle. This will help you avoid hemorrhoids, but also help you with everything else in your body, your heart. Get your routine screening, colonoscopy, stay on a high fiber diet. You can start with going to your family doctor, but frequently they will say, I don't see what's going on. And then you'll end up seeing somebody like me or one of my partners to first make sure you don't have one of the more serious diagnoses, and that it's something relatively easy to do. I would say that some of the gastroenterologists in town are actually pretty good at looking at hemorrhoids, that they will do bandings and things like that for you. And frequently then, if it fails their treatment, then they come to us. By the time they come to us, usually you need surgery. Any questions?
So Dr. Lee, I actually have a couple of questions that have come in online. So let's go to those first.
Mm-hmm.
One was about the skin tags.
Yes.
So what size are they usually? They asked, is it between a large grape and a golf ball, or what?
No, skin flaps can mean many different things. Okay, it could be a tiny 2 millimeter thing that you always feel, and it's sort of like that. That story with the pea with the princess that's sitting on like 8 mattresses or whatever, and they still feel it. Well, I think that would be something akin to that, because they're sensitive, and then because you can't see what's going on, all you can just say, oh yeah, I feel something there. A lot of times it's magnified in your mind that it's much bigger than it actually is. Okay, so for a lot of those, I would just say leave it alone. But if it bothers you that much, you're always thinking about it, fine, we can cut those out in the office. I've seen some pretty big skin tags. Now, the main thing I got to make sure that the skin tag is a cancer, okay? And there are certain things about skin tags that look like cancer that I could be able to tell you usually. And so for the vast majority, I would say leave it alone. Now, there's another instance where I would say you need to get that skin tag removed. So let's say you can't fully wipe yourself clean because there's always some stool that hides between one of the folds of the skin tag, and it just, you're always finding stains in your underwear and you can't keep clean. And so you wipe harder, and that causes pain and irritation. Okay, all right, that might be another reason to remove that skin tag. Again, skin tags are it's not really cosmetic because nobody really cares about what you look like down there, but they can cause these lifestyle, well, I don't know, they can interfere with your normal lifestyle because you could be thinking about it all the time, or it's uncomfortable. So those I would remove. Biggest skin tag I've removed is about 3 or 4 inches.
Okay.
That was not a cancer.
Okay.
Okay.
It was a skin tag?
That was a skin tag.
So, yeah, I had another question actually about symptoms of cancerous hemorrhoids.
So hemorrhoids don't cause cancer. So when we diagnose with, so here's the thing. A lot of times, and this is sad, patients will have rectal pain, and over a period of 2 or 3 months, it starts getting worse and worse. And the problem is what they had there was actually a cancer. But because they can't see it, they didn't have anybody else look at it. They didn't do anything about it. So it allowed the cancer to grow and grow and grow, and it starts growing into the muscles back there. And then that causes its own pain. A cancer was an ulcer. And by the time they come and see me, it's like, I look at it, it's like, yep, it's a cancer. We just need to biopsy it. But they said, I'm still having rectal pain. It's hard for me, and frequently it's hard for me to convince them that their hemorrhoid pain is actually their cancer. So I can't do anything about it until they start chemo or radiation or whatever, and the cancer starts getting smaller before they will experience any relief from that pain, because the pain is the cancer. So that's why, it's hard to say, what differentiates anal cancer pain from hemorrhoids? It's hard for me to say. I don't know that there are certain qualities of the pain that make things more suspicious versus another. And that's why I think that you need to get it checked out.
Okay. I know you talked a little bit about hydration for the prevention of hemorrhoids. So how important is that?
I think it's very important. Hydration achieves many things because it makes you not constipated. It dilutes out anything that's harmful in your body so that you can get it out, and keeps your pipes clean because you're peeing it out. And prevents kidney stones and all these other things that are helpful. And like I said, here in Tucson, you need to drink more than if you were living in Hawaii.
Right. I was going to say, yes, we are in the desert out here. So I'm sure, even if you didn't think it was for your hemorrhoids, it's definitely still important.
It helps with everything else. And also, your blood pressure, you need blood, and that maintains blood volume.
Great. Okay. Another question about the banding. So somebody had banding, but the hemorrhoids grew back. Does that happen often, or was she lucky or not unlucky at this point?
If the hemorrhoids grew back, that could be one of 2 reasons. A, she did not stop the things and the activities that caused those hemorrhoids to develop in the first place. She's still straining. She's still sitting on the toilet for like 30 minutes. And this is the problem. People think that sitting on the toilet is not a big deal. And it's actually a preferred way that they can get away from their spouses and their family. Because nobody will bother them there. But actually, it's not a good place to be because of the issues I described before. So it could be one of 2 things. That stuff never got addressed, and so therefore they sort of came back. Or the original hemorrhoid itself was too big. And so, the banding is not very effective. It just takes like little chunks out of the hemorrhoid at one time. Now, I've had patients who absolutely refuse surgery, and they just keep banding every 3 weeks, 4 weeks, and it took them like 9 months to a year to say, "Oh, okay, I beat it."
Okay, so
it's one of 2 things. It's too big to begin with, and I usually can tell, I don't think that banding is going to work for you, and or the other possibility is it did come back.
And the banding you usually do in the office? Was
Yeah.
that's okay? So that's in office. Okay.
What it is do you remember getting braces and that little rubber band? Well, that's what we use to band the hemorrhoids.
Okay.
That's the thing that we use to band.
Okay. And so how long that I'm assuming is that a pretty quick procedure then in the office?
5 minutes.
Okay. And then the pain, is there pain that
There shouldn't be pain.
or?
There shouldn't be pain. Remember, these hemorrhoids, you can only band internal hemorrhoids. You cannot band external hemorrhoids because that's where all the pain fibers are.
Okay.
So you can only band internal hemorrhoids. The way I do it, I grab the tissue that I want to band and ask you, is this painful? If it's a stinging, searing pain, I can't band that spot. I got to find a different spot. So and sometimes I keep finding, I can't find anything. And I was like, sorry, I can't band you because I don't find anything that I can band.
So you're banding up in the person.
Yeah, it's inside. So the anoscope is in place. A lot of times the anoscope itself is uncomfortable, but so I can't tell whether the pain is from the banding or from the scope itself being there. But most often I do the band, or I ask it, it's like, yeah, it's still a little painful, but it's not that bad. And then the pain goes away as soon as the scope comes out of the anus. The one thing would be, so therefore, if you have persistent pain after the procedure, they either banded the wrong spot where there's pain fibers, okay, and that's possible, or you developed a complication of banding, which is very rare. It occurs in less than 1 in 10,000 times. You developed an infection. So that's why pain after banding is usually treated in our office as an emergency. And you need to call me right away if you have pain. The discomfort that most people experience after banding is just a mild pressure type of discomfort. And that's all I would expect after a banding procedure. So if it hurts after banding, this is a problem. You need to call the banding person who banded you to make sure A, they didn't band the wrong place where there's pain fibers, or B, you're developing an infection and that needs urgent attention to be drained or taken to the operating room or something like that.
Okay. And do you, for the procedures that are surgical that you're having to do in the hospital, is that an outpatient procedure? Is it pretty?
Yeah, they're all outpatient procedures.
Okay. Okay. Great. I want to go ahead and that's all the questions I have here, but I do want to go ahead and just, if you're interested in seeing Dr. Lee, you can certainly call Arizona Oncology at 520-416-5700. And you'll be able to, make an appointment to see him if you've got any questions regarding hemorrhoid treatment. Dr. Lee, I want to thank you so much for being here. This was great. It was something I didn't know anything about, so it was good to hear what we can do if we have hemorrhoids, and then there's a lot that we can control with our lifestyle, which is super important as well. So thank you for being here. I'm going to wrap it up with our online audience, and I'm going to turn it over to you to answer any questions in person. So
okay.
Thanks for being here. So thanks again for being here today. We look forward to seeing you again. We will be back in on Tuesday, November 5th at 10 a.m. for a Medicare update for 2025. Super important to know what the new Medicare changes are for 2025. That will be with FEMA Council on Aging's Medicare Program Supervisor, Linda Kumalo. If you are interested in this class, please give us a call in the office. Our phone number is 520-324-1960. Also, next week, we have Diabetes Day on Wednesday, November 6th at 9:30 a.m. We will have 2 classes that are back-to-back that day. One is going to be on GLP-1s, navigating the world of diabetic medications. And the second talk is fiber, a powerful tool for blood sugar stability. Again, if you're interested, please call us in the office at 324-1960. Have a great day.